Dr. Kutsia, we can start.
Thank you so much. Good evening, colleagues, and welcome to another SAMA webinar. One of the many things that has transpired through this last few months regarding how one can interact with each other. So without any to do, let me start today. And I want to again say that we are able to each other on a virtual platform. And this, we have the number of people who can benefit from the information we share. Just to ensure that we are all adhering to the correct etiquette of these meetings, I would like to ask you all to mute your microphones if you aren't speaking and to switch off your cameras. You will see from the program that there are specific times allocated for questions and answer sessions. So I'd like to request you all to observe these and keep your questions for these time slots. Tonight's webinar is, in my opinion, an extremely important one, and it touches on a critical aspect of all our lives as physicians, namely measuring and reporting clinical quality. It's a safe way for doctors to improve. As an introduction to the people who you will be hearing from tonight, I would like to first welcome Mr. Louis Botha, the CEO of Health Quality Assessment, or HQA, as it's commonly known. While I don't want to delve too deeply into what Louis is going to say, let me just set the scene by mentioning that HQA performs an annual assessment of clinical quality in healthcare as offered by medical schemes by using various healthcare quality indicators with a view to improve the quality of healthcare as received by their members. There is so much more than if as some background into the work HQ, hand over to Louis. Louis, the floor is yours.
Thank you very much, Dr. Kutsia, and thank you very much to everybody attending for this opportunity to share with you a brief overview of HQA. So let's, is it not moving? The slide is stuck, it's not moving. Let me just
try the arrow keys on the keyboard.
Okay. Apologies for that. Now we can begin. I'd like to just share with you a brief overview of HQA, who we are and what we are about. And thereafter, the other presentations will give you a lot of interesting information. But we would like to share with you an opportunity to say measuring clinical quality is a safe way to improve. The moment we start talking about quality of care, a lot of questions come to mind. For example, what are we talking about? Are we talking about the quality of the structures in which we work? Are we talking about the processes we follow? Or are we talking about the clinical outcomes? And what data are we talking about? What systems? What quality reports? There are so many standards and protocols and guidelines and formularies and benchmarks. So which ones are we talking about? So the point I'm trying to make with this slide is we believe there's a very strong case for standardization before we can really say that we measure and report on clinical quality. And that standardization cannot happen without proper collaboration. A definition of quality of healthcare can be to say, was there the right diagnosis? Did that diagnosis lead to the right treatment at the right time, in the right setting, at the right price, and did that deliver the right outcome? So efficiency through consistently doing the basics right can be achieved. The strategy guru that we all know about, Michael Porter, said that good quality is less costly because of more accurate diagnosis, fewer treatment errors, lower complication rates, faster recovery, less invasive treatment, or more broadly stated, better health is less expensive than illness. He also said that in many healthcare systems, the problem is that practitioners compete at the wrong level. Because value in healthcare is the health outcome per rand of cost expended, and all participants have to compete on value, because when all participants have to compete on value, value will improve dramatically. So at the most basic level, competition on healthcare must take place where the actual value is created. If we look in our own country, there are various mandates when it comes to clinical quality. First of all, the Office of Health Standards and Compliance has got a function to check and monitor the compliance of quality in the various structures. And that mandate has very recently been expanded so that their duty now also include to do audits and monitor the quality of structures in the private health sector. In our engagement with them, they also claim that further down the line, they see their duty to measure quality of processes and even outcomes. Although they claim that it will take them a very long time to develop the capacity to monitor the structures of the various healthcare in the public and the private sector, and that they welcome that somebody else is already busy developing process and outcome indicators. If we look at the Council for Medical Schemes mandate, they also have an interest in quality, because in terms of the Medical Schemes Act, part of their duty is to protect the interests of beneficiaries at all time and to make recommendations to the Minister of Health on criteria for the measurement of quality and outcomes of the relevant healthcare services. HQA, on the other hand, is an independent, not-for-profit, public benefit organization aiming to become the leading clinical quality measurement and reporting organization for the whole South African healthcare system. And then you all know that at the end of 2019, the HMI Health Market Inquiry Report was published, in which in paragraph 8, they spoke about quality and the importance of measuring and reporting on quality for a sustainable healthcare sector. And in that report, HQA was acknowledged, because we also made submissions to them to say that they're aware that HQA for many years measured quality and report to health funders on clinical quality, and that HQA should expand that function to also work closer with practitioners and with facilities, and to begin developing outcome measures. So the background of HQA is basically that in 1997, basically the time when managed care was introduced in South Africa, a few people realized that there's a lot of information available on access to healthcare and the cost of healthcare, but very little information existed about quality. And if you can just think into a debate or a discussion or a negotiation about the cost of healthcare, if we do not know what the quality of that aspect of healthcare is. If somebody says you have to lower your cost, but you cannot say what that lower cost will do to quality, it's not a very strong position to be in. So the founding members registered HQA in the year 2000. Initially, it was just an organization for health funders and administrators, but very soon HQA realized that a wider collaboration was needed because there's a lot more input from other people that can enhance the development of health quality metrics. So an affiliate membership category was created. And I mean, to date, HQA has 18 medical scheme member organizations, but it has 22 other healthcare organizations as members. And those other include managed care organizations, pharmaceutical companies, doctor networks, a hospital group, and so on. Also industry bodies. So I already spoke about the HMI report that came out in November 2019 that suggested HQA should also become an organization for practitioners and facilities, not only for funders. So the HQA board agreed that is the way to go. And in 2020, the constitution of HQA was amended. It is still a not-for-profit and public benefit organization that now follows a multi-stakeholder approach. HQA has a representative and a balanced board of directors. Membership is now open on an equal status basis to funders, practitioners, and facilities. HQA today has an independent chairman. We have a clinical advisory board, of which Dr. Jackie Mew is the chair, and you will hear more from her later on. A technical subcommittee, and we have created practitioner and hospital subgroups. HQA also develops relationships with ICHOM and Hqa. I'm sure you're aware of Hqa. Hqa is a Dutch organization in the Netherlands that developed a number of clinical registries, and they report on the quality of that and work very closely with doctors in that regard. ICHOM is also an organization in the Netherlands that develop outcome measures, and they are busy developing international benchmarks. And the HQA board decided that it would be best to, from the beginning, see when we develop outcomes for the South African healthcare sector to see if we can align with international benchmarks. The relationship with the regulators, especially the Council for Medical Schemes and the Office of Health Standards Compliance, is very important to HQA. And we believe we have good working relationships with them at this point in time. At this point in time, the HQA board of directors consists of 12 positions, of which 6 are reserved for elected directors. And the ideal is that 2 of those will be from the funding industry, 2 from practitioners, and 2 from facilities or the hospital industry. There's also 6 positions for independent directors that will come from the academic world and other independents. The Office of Health Standards Compliance and the Council for Medical Schemes both have observer status at the board meetings. The current board is, the chairman is Mr. Bruce Dixon. He's independent. Dr. Bos of Steenekamp is the vice chairman. Then we have Dr. Angelique Coetzee. Representing practitioners, we've got Dr. Vio Kola from GEMS, Dr. Yunati Maslati from Discovery Medical Scheme, Matilda Marais is at Bonitas, Dr. Philip Madley is from SAPPF, the surgeons, Dr. Niri Naidu is from BankMed, and Dr. Roshini Naidu, Discovery, and Dr. Paul Soko represent Life Health, the hospital group. Shirley Colley is an alternate director and an actuary. HQA's current data and analytical partners are NMG, and included in that contract is access to Dr. Johan Von Sayer and clinical governance. And then HQA is also developing relationships, as I said, with ICHOM and Hqa, who are very keen to guide HQA with providers that collaborate to develop outcome measures applicable and relevant for the South African healthcare sector. So the task at hand is to create a safe space for doctors to get involved with submitting data, to take the leadership, to assist and co-develop the outcome measures, and receive reports on a confidential basis on that. To identify the thought leaders for the various disciplines, to work closely with patient advocacy groups when it comes to patient-reported outcome measures, to identify or develop the necessary clinical data sets, to develop or adopt the outcome measures and patient-reported outcome measures. We have to develop or acquire the necessary systems for submitting the data and make it easy to participate. There's some work to be done in terms of establishing a set of universal codes and definitions for quality measurement. Have to agree on the case mix and risk adjustments to be applied. Participation is voluntary, and as long as it is voluntary, reporting is done on a confidential basis. At the moment, for the last 17 years, HQA reported back to health funders that participated, and only Fund A can see their own results, but they also see how they compare to a benchmark. And when we speak about reporting to practitioners or to facilities, we say the same thing. Reporting, as long as it is voluntary participation, will be confidential. No blaming, no shaming. The only reason why we do this is to provide information back to the people that do the work so that they can see how well they are doing and where there's room for improvement, and that will enable them to make the necessary improvements if necessary. There is a duty at the HQA to inform and support the regulators. We believe there are aspects in the healthcare industry that prohibit people from improving quality. So this is more where it's an industry issue, not a specific fund or a specific practice not performing. We have to inform and enable the public, and we have to develop the necessary resources, the capacity, and the funding. So why should we collaborate? We believe it is the responsible thing to do. What is not measured cannot be managed. There's a window of opportunity to develop the outcome measures and the quality metrics whereby all of us will be measured going forward in whatever form the healthcare sector is going to be. If we do not do this ourselves, somebody else will do it on our behalf, and we might not like the way they do it, and we might not like the way we are going to be measured. So there's a window of opportunity to get this done ourselves. It's important to collaborate because a national standard set and benchmark cannot be developed in isolation. It is important because quality measurement is in the interest of a sustainable healthcare sector. It's in the interest of improved healthcare for the patient. It will transform the healthcare sector to become more patient-centric. So the idea is to collaborate on aspects like access to data, universal coding, case mix, and risk judgments, definitions of standards and values, how to measure and report, and compete on value. So I'd like to thank you.
Thank you so much for that. And that if you want to go somewhere, quickly go alone. If you want to go somewhere very far, go together. That's an old African proverb, if I'm not mistaken, and that's the truth. We need to look at that. And thank you so much for this insight into HQA. I think it sets a good foundation for our next speaker. Our next speaker, Dr. Johan Von Sayer, should be not unknown to most of us here because at some stage he also was part of SAMA and he worked at management in SAMA. So Dr. Johan Von Sayer is a medical doctor who also holds an MBA. He has 12 years experience as a general practitioner and around 19 years experience in health management, managed healthcare, health analytics, and clinical and procedural coding. He specialized in clinical and procedural coding together with the clinical analysis of health claims data. So without going into too much depth again into Dr. Von Sayer's resume, let me highlight some key aspects which I think are relevant tonight. Dr. Von Sayer's current experience includes advising on healthcare funders on the structure of benefit, measuring financial and clinical outcomes from interventions, developing provider profiling models all across the various disciplines, also developing clinical coding group methodologies, and advising corporate clients on health and wellness strategies. He currently also serves as a consultant to HQA, as Louis alluded to, and tonight he will be presenting the 2021 HQA Industry Results. So I think it's important for us as practitioners to listen to this, especially those of us in the private practice. It might add a lot of value. And I think there's still a lot of gaps. And as Louis have said, if we don't start to measure ourselves, someone else is going to do it. So without much to do, over to you, Johan. And it's again nice to have a colleague, an old SAMA colleague here tonight. Thanks. Johan, you muted.
Good evening, everybody. Sorry about that. I thought I'd be proactive and share ahead of time, but that didn't work with my. There we go. Right. Good evening, everybody, and it's good to see you again. See in inverted commas. What I've been asked to do is just work through some or an extract really, or a summary of the HQA results for this year. What we do at HQA is we look at largely medical schemes claims data on an annual basis, and then measure several metrics, and I'll go into the detail for you. And the 2021 report was released about 2 months ago, and that was really what triggered this presentation to you. So I really just want to try and make health quality a little bit practical, and if you'll forgive the simplicity, but you'll see I'll close the loop at the end, and then go through some of the industry results that we found this year. And I think there are 1 or 2 things that are quite interesting, particularly when we get to the benefit design and the behavior of our patients, or beneficiaries as they are called in the medical schemes industry, and then really just 1 or 2 closing observations to close this out. So as I say, if you'll bear with me, just a couple of slides on what is health quality, because I think it's important that we understand and have the same point of departure. When we talk about health quality, then there are several definitions, and the most relevant definition would probably be the definition that comes from the World Health Organization, where they make the point that quality of care is effective care, and what they mean by effective is that it complies with evidence-based medicine, and results in improved health outcomes, that it's efficient, in other words, that it optimizes or maximizes the use of resource and avoids waste. And the word here is efficient, and this is the one thing that I want to deal with straight up front. Efficient doesn't mean cheapest or cheap, and it is optimization or maximization of resource utilization, and we'll come back to that. That it's accessible to everybody, and that's the structure element that Louis spoke about earlier. Obviously, that it's equitable, safe, and that it's acceptable. So that's really what the World Health Organization, what their definition of health quality entails. If we look at a broader, more commercial definition of quality, and not necessarily only health quality, then it's about being fit for purpose, and I'll come to an analogy about that in a minute. It is about conforming to requirements. It is about cost, and there's a difference between cost and price. It's about standards, and Louis referred to standards earlier. It's about performance, and then it's about experience and patient experience in the context of this evening's conversation. If we go to the Institute of Medicine, which gives us a bit more of a clinical definition of quality, you can see the themes are the same. It's about effectiveness and efficiency, equity, patient-centeredness, again, safety and timeliness. And all of us have read about bad perceptions about health quality when it comes to timeliness and waiting times and waiting lists. So generally, if one looks at the definition of quality, there are many definitions. And I mean, if you go and Google health quality, you'll get pages of returns on the definition of quality. But the themes are generally the same. The other important thing that comes out of this definition of health quality by the World Health Organization is that it makes it clear that there is no single entity that is responsible for quality. And again, often the perception arises that, I've certainly sat in meetings and heard reports about doctors practicing suboptimal quality of medicine, medical schemes offering suboptimal quality of benefits, etc. The fact of the matter is that this is a multi-dimensional approach, and there are different responsibilities. Obviously, we need the right policy and we need the right strategy to be able to drive quality of care. The patients and the communities have their responsibilities. Doctors can offer patients healthcare, but if the patients don't consume that healthcare or don't take that healthcare, then there is a responsibility that sits with patients. And then obviously health service provision, and it's not only about doctors, I mean, there are also hospitals, etc. involved. And in this dimension, there would also be the medical schemes would also be part of that. So what I'm trying to say is that there are several dimensions to this, and different people have got different responsibilities, and everything needs to come together for this to work. So if we just use an analogy, and a very simple analogy for that, briefly, and compare health quality to an aeroplane. And I was at a conference many years ago where people also compared a hospital to an aeroplane, but that's a discussion for another day. The fact of the matter is, what does a flight cost, and what is the ticket price? And you can see again these 7 dimensions or components to quality that comes through. Does the flight compare to standards? What are the passengers' experience? Is that flight fit for purpose? Does it get you from Johannesburg to Cape Town in 2 hours? What is the value that you're getting for the performance, and is this adhering to the requirements and the expectations? ultimately that flight needs to land, and then a few things need to happen at the right time. And those of you who fly yourselves will all know that to have a safe landing, that aeroplane must be at the right place, at the right height, and at the right speed, all three at the same time. Otherwise, the landing won't work. And we won't go into the detail of that. The fact of the matter is that we have a very controlled environment, and everybody in that environment has got a role to play, including the passengers. So if we just compare that components of a flight, or those components of a flight, to healthcare, there are aviation rules. That would be the policies and the regulations and the stuff that Lee was talking about earlier. There would be a confined environment, which would be the medical scheme. Pardon the typo there would be passengers involved in the medical scheme environment. That would be the patients or the beneficiaries. We have a cabin crew. Those are the medical scheme administrators. And so we can carry on. But this flight needs instruments, and it needs to be navigated. And that's really what HQA is about. HQA is really the instrumentation of, as I see it, to navigate through the healthcare system and make sure that we ultimately have a safe flight and a safe landing. And when we think about that, the role of the pilots in this imaginary flight is that the pilots must navigate through the abnormalities or through the variables and deviations, because wind and weather will be different. Rules can't change that. Fuel consumption may vary depending on how heavy the aeroplane is loaded, how many passengers we've got on board, etc., etc. And the pilots have the responsibility to adjust for that. There may be other air traffic, and again, the pilots must adjust for that. And there may be technical issues with the aircraft and deviations with that. So the pilots really have within the system the responsibility to coordinate and adjust to deviations. So everybody's flying within the rules, and there are aviation rules and regulations. But ultimately, once that flight is underway, somebody must manage that flight. And those are the pilots. And I would liken medical practitioners to the pilots that need to manage their patients within this controlled environment, but recognizing that there are uncontrollable factors that must be managed at the same time. So in this environment, as I've said, HQA is really the management or the navigation tool, and it helps us to measure that flight. It helps us to measure the impact of changes or corrections that are made, and it also helps us to optimize the quality of the flight and ultimately the patient journey. So when we look at these results, they are not static results. They're really part of a journey and must be seen as a tool to manage ourselves and our patients through that journey. HQA is unique in many respects, and in South Africa, Louis made the point, and I'm not going to dwell on this too much. It's managed to get the support and collaboration of 80% of the medical scheme beneficiaries and members in this in South Africa. It has brought competitors around the table and around a common cause, which is health quality. As we know, medical schemes in South Africa, especially the open medical schemes, compete fiercely with each other, and certainly HQA has managed to bring those competitors together. Over the years and several years, and you'll see, I'll be showing you some 10-year trends just now. It has developed the ability to analyze claims data that come from several medical scheme administrators, in fact 7, and which is fairly unique in that regard. And then the HQA is certainly not claiming that it's arrived. There's still many challenges that must be met, but certainly some progress has been made. HQA is not unique because there are international examples. Many of you will have heard of the HEDIS standards, or the Health Effectiveness Data and Information Set, which is largely based on claims data, similar to what we do in HQA. The NCQA is an agency in the US that designs and measures quality metrics, and many of the metrics that we use come from the NCQA. The AHRQ, or the Agency for Healthcare Research and Quality, is also US based, and then NICE is based in the UK. But most of these examples, and many of them are now beginning to move toward measuring actual clinical data and clinical outcomes. But the bulk of the measurements are still being based on medical schemes claims data, and I'll show you now how that works. So if we look at the passengers or the industry that we're analyzing in HQA currently, as I've said, the HQA data set covers close to 80% of the medical scheme population in terms of beneficiaries covered. It's a smaller percentage of the medical schemes per se, but the reason for that is that there are a number of smaller medical schemes that don't participate in HQA. And this 80% number has been consistently there for the last 10, 12 years. And the rest of the statistics I'll come back to through the rest of the presentation. In South Africa, and that 80%, or the medical schemes industry in South Africa, and that 80% of the medical schemes population, close to a quarter of them are registered with one or more chronic conditions. And here we're talking about, and you'll be familiar with the chronic disease list, or the CDL chronic conditions, and those are the ones that we measure, because those are the ones that medical schemes register their beneficiaries for benefits for. But there are, as we all know, other chronic conditions that are not on the chronic disease list, and those beneficiaries are not counted in here. So at best, this is a conservative estimate of the burden of chronic disease in the medical scheme population in South Africa. You will see in this bottom graph, at the bottom left graph, we changed the definition. In earlier years, we actually measured people that we, based on their claims experience, that we thought they potentially would have a chronic disease, regardless of their being registered. So they were just claiming for, let's say, antihypertensives on a regular basis, and then we regarded them as having hypertension. But that caused discrepancies in the analysis and the reporting. So we changed that definition to the CDL conditions only in 2014. So to the extent that this 24% is an underreporting, this step change would give you an idea of how far this underreporting is. And one would be able to reasonably estimate that there's about a 2% underreporting here. Unsurprisingly, hypertension, diabetes, and HIV are the three most common chronic conditions that we're currently seeing in the medical schemes industry. In HQA, we follow we measure 4 categories of indicators, so we've got a prevention and screening category of indicators. In summary, the coverage of those indicators, and I'll go into the detail in a minute, or some of the detail, less than 15% of beneficiaries have had coverage in the prevention and screening category. Less than 50, or just under 50% of the beneficiaries had coverage in the antenatal care category, and about 40% of beneficiaries had coverage in the chronic disease management category. Now, I'll go into that in a bit more detail. And then we also measure various hospitalization admission types, and we use hospitalization admissions as a proxy outcome measure. And we really just say, if less patients are being hospitalized, we are assuming, and it is an assumption, that patients have better clinical outcomes and are healthier, which is and we go into some detail on that, and I'll come back to that. So this does deviate a little bit from the classic methodology in measuring health quality, and those are the ones that Louis was referring to. It was described by a gentleman with the surname of Donabedian, and he classically describes structure, which is about infrastructure and facilities. The process measures, which really ask the question, did patients have access to the right quality of care, which is and was the care provided in line with evidence-based medicine? And then the third dimension is the outcomes dimension. In other words, was there improved health ultimately, or lower mortality rates for that matter? So currently in South Africa, we don't measure structure yet, but in my view, structure is going to become increasingly important as we move toward NHI and as medical schemes expand on their so-called provider contracting or doctor contracting strategies. I think structure is going to become increasingly important. Process measures, we have a whole lot of them, and that is that we measure because we can measure them easily from claims data, and I'll show you some examples. Outcomes, as I said, we've got a handful of absolute outcomes or clinical outcomes that we measure, but mainly we are working with proxy outcomes, given the fact that we analyzing medical schemes claims data. So if we just briefly look at the prevention and screening or primary care dimension, we measure several indicators, and here we have bone densitometry in elderly women, cervical cytology in sexually active women, screening for colorectal cancer, HIV screening, and screening mammography. And you can see the coverage rates are generally quite low and have been staying consistent over time. So there hasn't been a decline, but there also hasn't been an increase. And if you look at the pictogram here, I mean, roughly about 2 out of 10 women have had eligible women have had a screening mammogram. Roughly about 30% of eligible women have had pap smears. 1 out of 10 eligible patients, males and females, have had a screening colonoscopy or a fecal occult blood, which is in this count, screening for colorectal cancer. And about 20% of, and you can see the graph here, about 20% of patients over the age of 65 have had a flu vaccination in 2020. And if we go and compare ourselves then to some international benchmarks, and there are several, you can see on the lines here or on the sliders where the international world is in terms of screening mammography. They're sitting at about 67% coverage in South Africa in the medical schemes industry, private sector. We are sitting at about 20%. Pap smears or cervical cytology, we're sitting at about 30%. And the coverage in the US is about 70. And one appreciates that the healthcare delivery systems are different. But the fact of the matter is that there are some. There's certainly this is what can be done. Colonoscopy, we're sitting about 10% versus 56% internationally. Flu vaccinations, we're sitting at 18.5% for it versus about 44%. If we look at antenatal care, again, the interesting thing here is that screening for anemia in pregnancy. Even there, we don't have 100% coverage when we look at the claims data. And then when it comes to screening for HIV, hepatitis, and TSH is in the newborns, and I won't dwell on that now. We're sitting at about a 50% coverage rate of patients that attended antenatal care. And let's assume that these patients, or the 80%, attended antenatal care regularly. Even then, the coverage of HIV screening and hepatitis screening in the antenatal period is relatively low. We're just seeing an interesting thing here in 2020, which was the COVID, was the COVID year, and we're still in it. The lengths of stay for both normal deliveries and cesarean sections increased. So it looks like, and it's by almost a day, and these are the lengths of stay in hospital. So it looks like patients may have been admitted earlier or kept in hospital longer during the COVID pandemic. for whatever reason. We don't know what the reason is, but it is just an interesting observation. If we look at chronic disease management, and I'm just going to go into a few quite briefly. The top graph here is just the age distribution of patients with hypertension or registered with hypertension. And we look at three so-called process measures or chronic disease management measures, being annual cholesterol screening in patients registered with hypertension, screening patients for hypertensive nephropathy, and screening patients for an increased blood sugar. You can see, if you follow the axis here, roughly about 50% of patients have actually had these screening tests in 2020. And again, this pictogram gives you an idea where we are. I mean, we're sitting around the 40–50% mark in terms of coverage of these indicators of chronic disease management. We look at diabetes, we have a similar sort of picture. For diabetes, we look at cholesterol screening annually. HbA1cs, the clinical best practice is 2 HbA1cs per annum for a diabetic patient. And here we have type 1s and type 2s combined. The reason for that being in the claims data, we can't really differentiate between the two. Screening for diabetic nephropathy and retinopathy, screening for peripheral circulation issues, in other words, podiatrist visits, and diabetics should all be on a statin. And then we've got a new indicator, which is why we've just got one data point there, where we look at flu vaccinations for patients with diabetes. Again, the pictogram gives you an idea here where we are. If you look past the graph, and it's really not, it's been improving. It's been improving a lot over time, but certainly the coverage rates for these patients is quite low when we look at these disease management indicators. And then the sliders at the top here give you an idea of where we are from a South African medical schemes point of view in comparison to what can be achieved or has been achieved and is being achieved in South Africa. Just a little remark around the podiatrist visit. There's a lot of conversations going on within HQA, and Louis mentioned the Clinical Advisory Board. The thing is, diabetic patients, do they all go to a podiatrist? I would argue no. Physicians and general practitioners that look after these patients can equally check for peripheral circulation issues. If we then look at the admission rates, and this is the outcomes part and the proxy outcomes that I referred to earlier, the top two graphs on the left-hand side, we have the admission rates of diabetics for any reason, excluding trauma and maternity, simply because people with diabetes can be admitted for many other reasons that are not directly related to diabetes. And then on the right-hand side, we look at diabetes-specific admissions. And you can see over time, and we must look at the context, that the management has been improving over time. And one would like to think, although we haven't done those specific causative links, and I'll come back to that now, it looks like these admission rates are beginning to trend downwards. We can't read too much into 2020 because of the impact of the COVID pandemic. But what we've gone and done is we've taken these patients, the diabetic patients, and we've said, let's take, and it's really an empirical thing, and we haven't prioritized these indicators at all. We've just simply said that if a patient ticks three or more of these boxes, then we'll regard them as being reasonably well managed. If they tick less than 3 of these boxes, then we will regard them as not so well managed. So if we then compare these well managed or high composite and the low managed or the not so well managed or low composite people to each other, you can see that the well managed people have been increasing in numbers or in proportion over time, and correspondingly the not so well managed people have been or patients have been becoming proportionately less over time. But look what has been happening to the admission trends of the better managed people over time. certainly indicating that there, and again, the definite patient by patient causal links haven't been made here. And there's several reasons for that. One of that is we work on medical scheme membership numbers as opposed to ID numbers. And when people change medical schemes, then we lose them, so as to speak, because they get a new medical scheme number. And for that reason, we're just looking at, amongst others, we're just looking at the proportions, but certainly the proportions are showing encouraging trends, and highlighting the fact that if these patients are looked after properly, and I mean, it makes sense, if these patients are looked after properly, then we can expect better clinical outcomes and healthier patients, as indicated by lower admission rates. Patients registered with ischemic heart disease, similar sort of picture. And here we look at the proportion of people that are, or patients that are on aspirins, that are on beta blockers, that have had a cholesterol screening annually, and that have had a flu vaccination. You can see the coverage rates in South Africa better than other diseases, but again, lagging the international trends. And all the international trends show us is what can be done, I believe. So it's a bit of an aspirational. So here again, we've looked at the better managed people versus the not so well managed people. And look at what that, there, the blue line is the proportion of people that are better managed with their admission rates, which are trending down over time. And then the people that are not so well managed are trending downwards. I must just, and Adam is here, he'll probably want to comment on this a bit later. These admission rates are adjusted for risk, or what we call risk adjusted. What that means is we adjust for differences in age, differences in gender, and differences in combinations of chronic diseases, because we all know that people with chronic diseases seldom only have one chronic disease. They, I mean, diabetics will 9 times out of 10 have hypertension as well, and etc. So that is all adjusted out. So despite the fact that that we've adjusted for all these additional chronic diseases, you can still see these downward trends. And amongst others, because of the risk adjustment adjustments that are applied, you won't see such prominent increases in the admission rates here. In other words, an opposite trend to what we have on the better managed people. If we look at the coronary artery bypass grafts, or cabbages, and coronary artery stents, these are just this is just the utilization of those stents over time, and cabbages over time. And I don't want to go into that into too much detail for now. It is just the utilization rates that we measure. Where I want to get to is, if we take these ischemic heart disease patients, the ones that I referred to earlier, and we look at the well-managed and not so well-managed individuals. And again, this is just a presentation of the previous graphs in a different manner. So the not so well-managed people have been reducing as a proportion of the total patients registered with ischemic heart disease, and the well-managed people have been increasing over time as a proportion of the patients registered with ischemic heart disease. Now, if you look at the bypass figures of the well-managed people, which is the green line over here, look how and again, the definite causal links haven't been made. Okay? All I'm saying is that management of ischemic heart disease in the medical schemes industry has been improving, and this doesn't adjust for different techniques, and the fact of the matter that, or the fact that there are newer techniques when it comes to coronary artery stents, etc., and that will have driven down coronary artery bypass grafts. This doesn't adjust for that. The picture is that we've got better management over time, and we've got lesser numbers of bypass grafts. And if we look at stents, then it's not as prominent. And again, COVID-19 has had its impact there. But look, for the better managed people, there's also a downward trend in the numbers of patients that have had coronary artery stents. these are just about the lengths of stay. In this particular data set, if we look at smaller data sets, then the length of stay in hospital for patients that are well managed versus those that aren't well managed is definitely shorter. In this larger data set, that observation is diluted a little bit. Asthma and COPD, similar sort of picture. Again, not great management overall. And again, in South Africa, in the medical schemes industry, lagging the international benchmarks quite significantly. Again, and I don't want to dwell on this too much once more, but the point is that patients with COPD have got high admission rates, and it's a small proportion of people, and so there's really an opportunity to optimize the utilization of healthcare resources. I mean, what this graph shows us is that roughly somewhere between 30 and 40% of patients registered with COPD will be in hospital in any given year. And that trend it's come down a little bit in the last 2 years, except that we can't read too much into 2020 due to the impact of COVID. So that's really just a snapshot of these so-called process measures that we measure, and some of the proxy clinical outcomes that we're beginning to trend. The question that we've been confronted with, and that's aside from the clinical side of health quality assessment, is what is the impact of benefit design on all of this? In other words, do patients that are on less costly or less rich benefit options, are they receiving lower quality of care? And is benefit design a driver of that? And what I'm going to show you now is really the reason why I started off with the analogy that I did. So generally speaking, and just briefly, we have divided benefit options, medical scheme benefit options, using different methodologies. So firstly, we look at the out-of-hospital benefits, and we've just crudely grouped benefit options into 4 groups, being the traditional benefit options, the ones that we've known for years, where the out-of-hospital benefits are paid for by the scheme. Then we have savings options, and those savings options where when the savings is finished, they're finished, or are finished, and they're finished. Then we have the network options, and then we have what we call the savings plus options. And those are the ones that those of you who are in private practice will be familiar with, where patients have savings, and then they have a self-payment gap, and then they have above threshold benefits. So that's really what we have here. The trend that I want to just highlight to you is that patients are moving away from the traditional options over time. A proportion of them, or there's stability around the savings options. An increasing number of them are moving toward network options, and they're moving away from these more benefit-rich savings options. So there's a move away from these savings options and these traditional options. If we take those same options, we now categorize them in a slightly different manner and say those benefit options that only offer chronic disease list, those PMB chronic conditions benefits, those that offer the CDL conditions plus 1 or 2, and those that offer the CDL conditions plus many more chronic conditions. And we know that there are a few of those benefit options around. You can see again in 2020, well, over time, there's been a downward trend in these CDL plus and CDL double plus options, and people have been moving to the less benefit-rich options. And then if we just do a simple cost categorization, you can see that people are moving away from the medium and more more expensive benefit options to the less costly options. Remember that here we're looking at 2020 data. So that was before COVID-19 was even a word, when people decided when to go into these options. So certainly when these options were made, one can see that the economy was also playing a role here. So the important thing of this slide that I wanted to highlight to you is that if you look at the average age in each of these 4 categories over here, you can see when it comes to the more benefit-rich options, the average age is higher. So it looks like, and I've got a slide on that just now, another slide on that. So it looks like when people become older and their healthcare needs increase, that they start choosing more benefit-rich options. Okay? And that, again, makes sense. I mean, most of us are risk-averse, and if we think our healthcare needs are going to increase, then we would obviously want to improve our insurance, because that's, in effect, what is happening here. So if we look at that, and just briefly in the next few slides, as I said to you, we've got several process indicators that we measure, and to be able to look at them in a combined manner, we take those indicators and we score them. And really, if a scheme or benefit option, if the combination of those process measures is equal to the average of the rest of the industry, the score would be 0. And if the coverage rates are above average, the score would be positive, and below average it would be negative. So 0 is average, above average is better, and below average is or a positive score is better, and a negative score is not so good. But this is just a methodology that allows us to compare different cohorts of patients to one another. So if we now go and take these same option groups, and remember I showed you the graph over here of older people, and we can assume that older people have got higher healthcare needs, they've got more chronic conditions, and they are probably a little bit sicker. You can see how this is, as I said, a combination of the process measures over time. So you can see all the process in all 3 years that we analyzed. In these more benefit-rich options, the scores were positive. But if we go down to the network options, the scores go into negative territory. So it looks like the quality of care consumed by beneficiaries belonging to the more benefit-rich options is higher than the quality of care consumed by the beneficiaries or patients belonging to the lower benefit options. So not only the network options, you can see that in the savings only options is the same thing. We see the similar sort of trend when we look at the high cost benefit options versus the lower cost benefit options, with the average ones in between. And then if we look at the chronic disease cover, the CDL++, in other words, those with CDL plus 4 or 5 additional and more additional chronic conditions, better quality scores than those with CDL only. So it does look like the choice of benefit option has an impact on patient engagement. And you can see that if you add the ages to each of these groups, then you can see the ages in each of these groups are higher in these more benefit-rich options than what they are in the lower benefit categories. And that really and that's where the theory comes from, because that is what it is at this stage, is that sicker patients choose more benefit-rich options and appear to engage more with their medical scheme and the services offered. These are just, if we take those 4 categories that I explained to you earlier, and the thing that we must just look at here, so the dark green one is antenatal care category. The blue one here is chronic disease management, sorry. The light green one is HIV management, and then the gray one is primary care and screening. So you can see, and the bulk of the indicators are in the chronic disease management and prevention and screening categories. And again, you can see a similar picture where patients or beneficiaries who are on the more benefit-rich options have got a higher level of engagement than patients on the lower benefit options. And remember, these patients are seeing the same doctors. So it is not as if, and it'll be difficult to convince me that a general practitioner is going to treat a patient on this benefit option or a higher, a more benefit-rich benefit option differently to a patient that's on a savings option or on a network option. So there is an element here of patient engagement and patient patient engagement relative to their disease profile or health profile. Angelique, I'm almost done. And here we're just looking at this in a different manner. So we've taken these beneficiaries and we've said, let's divide them into those that have, in each of these years, 2019 and 2020 respectively, have seen a GP and a specialist, or a specialist only, or a GP only, or none of them. Okay. In other words, they didn't see a doctor, they didn't see a GP or a specialist. And again, you can see the moment they engage more and they see a GP and a specialist, or a specialist, that their quality scores improve. Okay. So there is, again, and that's got a lot to do with patient engagement with the system. So if we just look at this in summary, again, back to these four categories. I mean, certainly COVID has had an impact, because you can see that in the prevention and screening category, the score there have been consistent increases, and we can draw a line over time. Here we've just got a 3-year view, but the scores have improved from 2018 to 2019, and then we had this dip, which is a reduction in engagement by patients in 2020, and that's courtesy of the COVID pandemic. People were just scared to go to the doctor, and we can see that in, not necessarily in this data, but we can see it in other forms of analysis. Antenatal care, interestingly, has increased over time. Sorry, I forgot to show you this. Look at antenatal care look at antenatal care where patients saw a specialist only with this low quality score on those 4 indicators for antenatal care, which I also found quite intriguing and interesting. I don't know why, but it is quite interesting. The chronic disease management has also decreased in score in 2020, after it has been increasing consistently over time in prior years. And then with COVID, again, those of you who are in private practice will know that admission rates have come down quite significantly in 2020, and that was largely because of elective procedures that reduced in number quite significantly in 2020. So to round this off, I mean, I think the impact of COVID is clear, and it has impacted the results of the analysis that we've done for 2020. But certainly the quality of care that's being consumed by beneficiaries in the medical schemes industry is not as optimal as one would want it to be. But there are multiple factors that are causing this problem, to the extent that a problem exists. And that problem also spans across multiple areas. And I showed you the triangle, that there are several drivers of quality in any system, and also in the healthcare system. But I don't think it's all negative. Some significant improvements have been made over time, and I've shown you reductions in some admission rates, and that there are positive outcomes that are beginning to emerge. And certainly the medical profession is a key stakeholder here, because it's about how do we get patients to engage with the system, and how do we move from a reactive provision of healthcare to a more proactive mode and improve on these outcomes these positive outcomes that we are beginning to see. And I guess that is the conversation, and Jackie will touch on that. Just for interest sake, in closing, Angelique, just a very last slide. What we've done here is we've taken all the benefit options of all these medical schemes that have participated in the 2021 HQA survey, and we've plotted their scores, that -2 to +2 that I showed you earlier. There's 0, there's the average. And then we looked at the proportion of patients on each of these benefit options that were admitted with COVID. And you can see on the left-hand side of this x-axis here, or horizontal axis, we have the lower scores here and the higher scores on the other side. And you can see that the higher the score goes, and there's not a lot of, and there are some data issues here, so it's not an absolute analysis. So this is really just a beginning of some work that we've started in HQA, but you can see that there's definitely a positive correlation with lower admissions, patients that are COVID admissions for patients that are better managed than those that are not so well managed. So yes, COVID is about comorbidities, and I don't want to go into COVID. I'm not an expert on that. Fact of the matter is that if we look at a healthcare system and patients are better managed, and we've got a greater emphasis on proactive care, we can also impact on unfortunate events like COVID-19. With that, thank you very much, Angelique. I'll gladly take questions if there are. Thank you.
Thank you so much, Doc Van Sayer. And I think we can tackle the questions already that are before us. First of all, I would like to thank Louis Botha for his presentation earlier on. The part that we are going to deal with now is the questions that have been raised. But before we leave the questions, or we start with the questions, I would like to, Louis Botha, to just touch on the few that I have here. The collaboration that he talked about, collaboration between HQA versus the OHSC and CMS. Do we envisage any collaboration in that regard? Because it looks like there is some interest that these agencies are dealing with. So that's the first question with Louis Botha. The second one is, I think you did touch, if I'm not mistaken, but you may remind me, the voice of the consumer or the user of healthcare. It looks like it is part of your board or your structure, doesn't seem to appear in your structure. I think those are the questions I have for Louis Botha. Can I just allow him, if he's still available, to respond? Then we'll go to Dr. Van Sayer's questions.
Thank you, Dr. Mazukwa. I'm happy to answer those two questions. The first one is that the collaboration that HQA is establishing with the Council for Medical Schemes and the Office of Health Standards Compliance is active. I think you are aware that the Council for Medical Schemes for several years also did some quality measurement reports, and then every year there were some differences between the way HQA reported and they reported. So HQA engaged them, and we drafted a memorandum of understanding between HQA and the Council for Medical Schemes, whereby the arrangement currently is that the Council will rely on the work that HQA is doing, and it will have observer status in the HQA meetings. So we are completely transparent with the Council for Medical Schemes, how we do our work and so on. And there's an expectation that HQA every year after we release our annual results, that if we pick up anything that we feel requires some regulatory intervention or review, that will help to improve the quality of the industry, that we will report that to the Council for Medical Schemes, because they have a duty, as I said, to report to the Minister of Health. We are in similar discussions with the Office of Health Standards Compliance. And as I said, they do see this kind of work as part of their role, perhaps in future in the NHI environment, but they welcome the fact that HQA is already this far and that we are prepared to take it even further into outcomes measurement. And we do it in a similar way with them, completely transparent. Yeah. So then the other question was about the patient. HQA always had, yeah, but HQA is very aware of the patient as actually the center of the healthcare industry. Everybody should be more patient-centric. And for that reason, since the inception of HQA in 2000, we had a director on our board, a representative of the South African National Consumer Union. That director, unfortunately, in the beginning of August, passed away due to COVID. So we have to find a replacement for her. But we see ourselves working very close with patient advocacy groups going forward, especially when we begin designing patient-reported outcomes. So it's definitely part of our strategy going forward.
Thank you so much, Louis Botha. I think you've been very much clear on your answers. Can we move on then to Johan? Johan, we've got questions for you, and thank you so much for your really insight and your clear, demonstration of what we are here for. I think there's two questions that are on the group here, and the other ones have been answered already. Let me take the first one by its screening program for colorectal cancer in South Africa. At what age are the patients eligible? How often should they be scoped? And who performs such screening endoscopy? That would be the first one. The second one relates to HIV. Dr. Major says, I noticed that HIV analysis was not mentioned in your presentation, although it is prevalent in the majority of South Africans. You alluded to it being the top 3 of the chronic conditions. Those are the 2 questions for you for now. I will come later with other questions.
Yeah. Thank you, Dr. Mzukwa. I'll deal with the second one first, if you'll permit me, and that is, I mean, I really just gave you a snapshot of what we've done, and it's not as if we're not measuring HIV management in HQA. This was just in the context of this particular presentation. I didn't show that, but we're certainly looking at things like medicine possession ratios and CD4 counts and viral loads, although the clinical guidelines in that regard are changing, and we try and align, and Jackie will allude to that a little bit later as well. We constantly updating these indicators to align them with the latest evidence and latest clinical guidelines. So absolutely, we do measure HIV management. It's just that I didn't focus on that this evening, particularly in the interest of time. Then when it comes to colorectal cancer screening, we have a high-level indicator that we look at from a colorectal cancer screening point of view, and we include any screening methodology. As you saw in the slide, the coverage rates of screening is really low. So what we did there, and again, Jackie will probably fill me in here, but what we try to do there is cast the net as wide as we possibly can. So we've included fecal occult blood, we've included colonoscopies, and so to try and as I said, cast the net as widely as we possibly can. Despite that, we've got low coverage rates. And we're counting coverage rates for, and that what I mean by coverage, and there's been a question around the coverage, which I see Adam has answered, is the proportion of people that are eligible that have had a test, any test, or screening test for colorectal cancer. And as I say, that ranges from the most basic test to the most advanced screening. So we don't look at what sedation is provided, where the colonoscopy is performed, by whom is performed. All we look at is to look at, did this patient have a colonoscopy, yes or no? I can't remember the exact cutoff age. Adam's got a better memory than me, but I think we're looking at all patients over the age of 45 that should have that should be screened for colorectal cancer. And then again, as some of you in the audience will know much better than I do, there are also varying clinical guidelines when it comes to screening in terms of the frequency of or the desired frequency of colonoscopies and screening for colorectal cancer. At this stage, we are measuring coverage once per year, which is probably too frequent, and that's one of the indicators that we are that is under review currently in terms of the indicator definition. Adam wants to fill me in there. Thank you very much, Adam.
Okay, all right.
Brilliant.
Dr. Adam?
You'll indulge me, Dr. Mzukwa, and good evening to everybody. Just to fill in on some of Dr. Von Sayer's observations about colorectal cancer screening. The age is 50 that we start with. So it's all patients over the age of 50. And when we talk about frequency, it's annual only for the fecal occult blood test. We count over a 5-year period for the scopes, for the colorectal colonoscopies. So it's either a fecal occult blood in the last year or a colonoscopy in the last 5 years is the definition that we use. And that definition, as Dr. Von Sayer says, is constantly under review. And I think you'll hear more from Jackie when we get there.
Thank you so much, Dr. Whilst we're still with you, Johan, I think I've got a few other questions that I think you would assist answering. One, I appreciate the fact that you spoke a lot about the role players in quality assessment, you know, in terms of policy, the healthcare provision, the users, because in most cases, you find that when people talk about quality, they only looking at the provision of services. But I do appreciate that you touched on that clearly. The other thing that I wanted to know, why is that there are medical aids who are refusing to participate in HQA? Is there any particular reason, not necessarily wanting to know the names of the medical aids, but just the reasoning behind their refusal? That's point number one. Point number two is on the some of these screening programs when it comes to, for example, management of diabetes mellitus. It looks like the dietitian is out of the equation, and we know the huge role that is being played by a dietitian. I think those are, maybe let me just add just the comment. The other comment that I have regarding these benefits, that at times we find a problem as providers of service where we want to screen a patient, but the patient refuses because they say medical aids, last year when I did this test, doctor, the medical aids didn't pay for it. So you want me to have debt again this year? I am not going to do the test. So you find yourself where you can't do certain tests because they are not covered or they are not being paid for, and the patient would refuse to do the test again the following year. Over to you, Johan.
Thank you very much, Dr. Mzukwa. I mean, I'll just deal with these one by one. I mean, I've made the point that the quality of care is not the responsibility of a single stakeholder or stakeholder group. I mean, there are several stakeholder groups, and and each of them have got a role to play. And that ranges from policymakers through medical schemes, through patients, through to healthcare service providers and healthcare practitioners. And all of them have got their role to play, and all of that must be brought together. And I think that's the challenge that we're facing as a system, is that, and that's the conversation, and that's why HQA is reaching out to the medical practitioners, because they are also an important stakeholder in this whole conversation. So it's a multi-stakeholder approach. The reason for and the trick is, and there's no organization, as you are would be aware, there's nothing in South Africa that brings all these stakeholders together. It's all in silos. We've got the Health Professions Council, we've got the Council for Medical Schemes, and we've got several other regulators. The trick is going to be to bring them together about a single common denominator, and that's our patients. And you know, and I guess that's the big question: is how do we bring that together? And I certainly don't have the answers. The reason for the refusal of the medical schemes, as I said, I mean, there are one or two of the larger medical schemes that are not participating in HQA. We don't know the absolute reasons for that, but the majority of them have got their in-house capabilities of measuring these sort of metrics, and that would be their reason. And then you know, some of them for some reason don't see the value, you know, in benchmarking against an industry benchmark. And again, you know, it's not my place to comment on that. And then the majority of the smaller schemes, it's really just an affordability thing. I mean, these are small sort of employer-based schemes, and their interest is in looking after employees as best they can, and for that reason, they typically do, you know, choose to not participate in a lot of the industry initiatives. The role of the dietitian is, I mean, all I can say is thank you for raising that, and I'm going to pass that ball to Jackie. She's the chairperson of the Clinical Advisory Board. And I would certainly agree with you that that is an indicator that we should look at. Again, that's the value of conversations like the one that we're having here, is because the indicators that we're looking at are not comprehensive and are not all-encompassing. And as I said, you know, HQA doesn't claim to be perfect. And if we can have these sort of value additions through conversations such as these, then that will be great. So certainly, you know, from a clinical advisory board, I'm sure Jackie will take that on board. And then medical schemes not paying for care and not paying for a test. You know, what we are looking at here from an HQA point of view is prescribed minimum benefits. So those benefits should be available by law by any medical scheme. Now, obviously, there are these so-called baskets of care, and what the baskets of care are about is that they also based on evidence-based medicine. So for example, a basket of care would include 2, maybe 3 HbA1cs for a diabetic in a year. So if there's a 4th HbA1c, then the medical scheme wouldn't pay for that. And patients often misinterpret that as medical schemes not wanting to pay. And that raises a whole other issue, and that is, you know, why did that patient need 4 HbA1cs in a year? You know, is it that there's a lack of coordination of care, that there's not a communication between the GP and the specialist, so the GP is doing HbA1cs on the one hand and the specialist on the other, or whatever, you know? I mean, that's just one example of things that can happen. But and once again, I mean, one needs to unpack these issues, because to the extent that the care that is being prescribed by the practitioner is, you know, in line with evidence-based medicine, and by extension, in line with those minimum baskets of care, the medical scheme should be paying. And if they're not paying, there must be another reason for that, which we must try and understand.
Thank you very much, Johan. I think that because of time, let me just quickly give you the last 2 questions. There's one that says, Has your assessment influenced benefit design package for out-of-hospital cover and increased GP consultation benefit? That's the first one. And the last one, it says, I would stop with this one. It says, medical aids will not pay if patient is admitted for colonoscopy. Will pay if done in the specialist room. In Durban, only one specialist. So much, Johan, over to you.
All right, thank you. So, so the benefit design package, and I didn't have slides on this, you know, but a prime example of where benefit design and the prescribed minimum benefits have an impact on the quality of care provided is in the psychiatric field, where we have this 21-day admission benefit, and then after that, you know, the benefits run out. There are other examples, and that is exactly why HQA is working hard on its relationship with regulators like the Council for Medical Schemes, because ultimately, you know, that's where the prescribed minimum benefits are being designed and being regulated, and you know, and that's really the area where one can address these sort of issues at a industry level and uniformly. So, but I mean, as you all know, you know, to work with regulators, changing regulations is a slow process, and there are many other considerations that must be taken into account. So it's a matter of time. The direct answer to the question is no. You know, from a regulator point of view. However, what we have been seeing in many medical schemes, and it's not all of them, but in many medical schemes, is that they're taking these results seriously. And you saw those increasing trends over time in the graphs, is where medical schemes have actually increased their benefits and are putting more focus, some more than others, but they're putting more focus on patient communication, patient education, working on their relationships with doctors. And again, some of the GPs in the audience will be aware that GP profiling is, albeit slowly, beginning to move away from financial profiling to quality profiling. You know, have your patients had a pap smear? Have your patients had their HbA1cs, etc.? So I think, you know, it's a change management process and it takes time, but you know, I do think that we are seeing some positive trends. Just on the colonoscopies, yeah, look, I mean, that's optimization of resources, and there is a view that a screening colonoscopy is an out of hospital procedure, and medical schemes have got their guidelines, and you know, I mean, I can't speak for individual medical schemes, but I am aware that there are some medical schemes that try and doctors to do colonoscopies in rooms. But as far as I'm aware, and I stand to be corrected, as far as I'm aware, most medical schemes are now including day theatres in that. So because of the issues around safety in rooms when it comes to endoscopies, etc., etc. So if there's an issue around a particular medical scheme, you know, then I think the conversation must be had with the medical advisor of that particular medical scheme around that. I'm sorry, I don't have a definitive answer about that, and HQA doesn't drive those guidelines, but there is a drive toward diagnostic colonoscopies. I'm talking about diagnostic as opposed to interventional colonoscopies that medical schemes, in the interest of cost efficiency, are trying to incentivize doctors to do those at the lowest level of care, lowest possible level of care.
Thank you so much, Johan, and thank you so much for your insight on these matters. And thank you so much to Louis as well. I'll now hand over to Angelique.
Thank you so much, Dr. Muzukwa, for managing this question and answer session. Next, but not the least and not the last, definitely, I'd like to introduce Dr. Jackie Myers. She's a health economist and a researcher at the University of the Witwatersrand as the division director at the Health Economics and Epidemiology Outcomes Research Office, or commonly known as HERO, which is a division of the WITS Health Consortium. Dr. Myers is also the chair of the HQA Clinical Advisory Board. She has worked in the field of evidence-based medicine, health economics, and health policy for more than 20 years. It's a long time, a lot of experience. In addition, she is a member of the pricing committee of the Gauteng Provincial PTC, past chairperson of the Pharmaceutical Care Management Association of South Africa, past director of the EVIDIM collaboration, and serves on the editorial guidelines subcommittee of the South African Medical Journal. She has a B.Pharm degree and obtained her PhD in neuropharmacology from the Faculty of Medicine at London University. It is a great honor to welcome Dr. Myers here tonight to speak on a doctor-led quality measuring process, a safe way to improve. With that, few words over to you, Dr. Myers.
Thanks very much, Dr. Kathia, and thank you for the introduction, and it's great to be on this webinar. I'm very mindful of the fact that we are getting late into the evening, so I'll try and keep this fairly short and sweet. It really all boils down to a plea for, for input and advice on some of the things that we would like to take forward. So I'm going to take you through my presentation, as I say, fairly quickly. And then, let me just get it right. See if it'll work. There we go. Okay, hopefully everyone can see that. All right. So as I say, I'll move through this fairly quickly. We've had a lot of discussion around the HQA data set and the different indicators and so on. So I'm not going to dwell on those too much. Really what we're hoping to engage with the SAMA members around is drafting some set of indicators for the healthcare practitioners. So working with the doctors in coming up with a sample set of indicators that we could start walking this journey together. And that's really why we are here today. And then perhaps there'll be time for some discussion or questions afterwards. But really, the indicator set starts with the evidence base. And so we look at treatment guidelines, international guidelines, local guidelines, whether they're systematic reviews and so on. So it's a wealth of different information that we pull together in order to get to some kind of a statement of care, which is, for example, all type 2 diabetic patients should be monitored on a regular basis. And that leads to a standard of the quality of care. So in order to achieve that, monitoring of diabetes is best achieved by measuring HbA1c in all type 2 diabetic patients and so on. And that then eventually leads to the indicator, which is really quite a technical thing. And I'll go through that in a little bit more detail, but I think it's important to put it into the context of where it fits into the sort of the whole clinical paradigm of moving from a guideline to how you would measure that point of care has been achieved. So in terms of health quality indicators, they're really about building blocks in the assessment of quality of care. They can't tell you this is good care or this is bad care. It's not about that. It's about inferring some kind of assessment about that care and providing a benchmark against which to measure. So how's everybody else doing? How are you doing compared to everyone else? Indicators have to be measurable. And so you'll see that's why we get quite detailed and technical about how we measure them, because that allows for the consistency of the way that the indicators are used to measure quality of healthcare, but they can't provide definitive answers. They can't say, well, this is how you should be managing your patients, or this is how the benefit design should change. It can raise red flags, and it can say, well, there's a lot of variation in this particular indicator, which suggests that there are things that are not necessarily working that well, and you need to go away and unpack it. Is it because of the way the benefits have been designed? Is it the way people are interpreting the guidelines? So there are many different nuances to understanding what goes on behind the indicator. All it can do is say, well, here's something that we perhaps need to look at. So at HQA, as I think Louis and Johan have both mentioned, we have the Clinical Advisory Board. And the Clinical Advisory Board is made up of many different stakeholders. We've got people from the medical schemes, from the administrators, from doctor groups, from the hospitals, the Council of Medical Schemes, OHSC, even a few pharmaceutical companies are thrown in for good measure. So it really is a very broad range of stakeholders, and we have lots of really quite robust discussions at the CAB. But essentially what happens at the Clinical Advisory Board is the indicators get developed. And at the moment, we develop indicators based on the claims data, because that's the data that we have to work with. We would like to move in time towards including clinical data so that we can really properly measure outcomes. But it's a journey, and we have to work with what we've got. And so I think from that perspective, that's why we're wanting to start to look at some kind of a sample set of indicators. What would be a testing ground for starting to measure indicators in the doctor space, and how would you want to go about doing that? I think this is the buy-in from you as the healthcare practitioners is absolutely critical. It's not going to move forward without that. So there are steps in the process. And really, we're looking at this at kind of two different levels. So, and I'm sure you've all been subject to this. Every medical scheme has got a different way of measuring things. So you end up by getting a whole bunch of different reports, and the one says that you're doing okay, and the other one says, well, no, you're not up to scratch. And it's frustrating, and there's no standardized set of measurements or indicators. So that's something that as HQA, we would really like to work with the doctors to try and come up with some kind of standardized set of indicators, even if it's just one or two or three, and also some standardized definitions. And they've got to be meaningful and useful. So it's got to be something that says something about what can be done, what can be actioned to improve in the quality of care, and it has to be context specific. From an individual's perspective, what we really want to be able to do is produce something that you can say, this is useful. It's for me to be used to have a look at how the quality of care is going in my practice. And one of the benefits of working with a big data set, for example, like the HQA has, is it's all the patients, all your patients in all the schemes that are participating in HQA. So rather than being reported on by, how you're doing in one medical scheme with all their patients, but you can't see what's happening. You may have a practice that's very diverse with patients from many different schemes, as well as cash-paying patients. So the idea is really to try and be more inclusive in terms of how those benchmarks are developed and identify areas of action or where improvement can happen. And again, they have to be useful. And that's something that we would really be looking to work with you about and say, well, what would you find is useful? And what kind of questions would you want answered that you think would be able to shed some light on things that perhaps are not necessarily all that clear, or something that you haven't focused on before. I do think what's important is to understand is that the indicators provide an overview of care during the whole year for all your patients. So it's not about saying, well, for Mrs. So-and-so, this was the right thing or not the right thing, or she didn't go off and get her HbA1c. it's about an overview of that care. And some of the sample indicators that we've been thinking about, we kind of picked out some of the most typical ones and that we are already obviously measuring in the HQA data set. But the field is wide open to deciding what indicators would be useful to measure, obviously within the context of what data we have as a starting point, but there's no reason why we can't gradually move towards introducing different indicators where we don't necessarily have the data, as we go down the line. And so some of the common ones, and we've mentioned this, and I feel like this is my go-to sample, is the HbA1c in diabetes, but also to mention, as Johan did, around the question around HIV. For example, measuring viral load in HIV or flu vaccines in high-risk patients. There's already been discussions around screening for breast or colorectal or cervical cancer. We do other screening indicators as well. These are just some examples that could be developed into indicators. So the example that I'm going to give here around diabetes is the question is, how well are my diabetic patients being monitored? When you take that into an indicator space, you have to look at the guidelines. What do they say? Well, you should have 2 HbA1cs in a year. What can you count? Well, you could count anybody who's only had 1 or anybody who's had 2 or more. The population would be your diabetic patients, as Johan said, as chronic, registered on the chronic benefit. And then the count would be who's claiming, how many claims have been done. And then the measure would be as a percentage. So how many HbA1cs have been claimed in the total population. And the output of that is really to explore reasons for why there is variation in the results. And as we've said before, it could be many different things. It could be that your patient just decides not to go off and have their HbA1c, or they pay for it out of pocket and it doesn't get covered through the claims, although it is a P&B, so it should be. So what we would like to move to is that next step. Well, then what is that result? And what can be actioned on those results? A lot of this is around translating the technical detail into something that means something at a clinical level. So we have a whole lot of work that gets done behind the scenes that Adam is really our actual expert in this, and how they do algorithms and they link data and so on, trying to make sure that it's representative of what's happening in the clinical practice, but bearing in mind that we are collecting technical information. And so we have to understand the limitations of that data. But what's absolutely critical about that is reporting back to yourself, to as a national benchmark. It has to be confidential, it has to be easy to use. So if we look at some of the confidentiality issues, and I'm sure all of you have been subject to various different popular requests and requirements, and I think it's causing a lot of stress in the system at the moment. But just as an assurance, the data that HQA currently collects is held in the highest and strictest levels of confidentiality. The data is encrypted when it gets sent to the actuaries. The analysis kept is done independently, and we only really see the aggregated data when it comes back. So patient data is anonymized and confidentiality is maintained, and that same thing would happen at a practitioner level. And obviously we all have to be properly compliant these days. So there are some limitations and challenges to measuring quality of care using these indicators. And we acknowledge the fact that this is a very simple representation of what can be very complex phenomena. So there are lots of things that can't be measured. The values, compassion, caring, those kind of things, what health priorities, those can't necessarily be measured. And there's always scope for indicator creep, because there's so many wonderful things. You go, oh, what happens if we measure this? Or it would be so interesting to do that. So it's also about managing expectations on what can be done. And there are challenges with using claims data. And certainly, I think one of the fears is that indicators or quality measures are used as a basis for payment. And that is something that we certainly, that's not on the agenda here. It's about this, as I think as Louis said earlier, this is not about reporting back to the schemes. This is about creating indicators that are of value and are reported back to you as the doctor for you to use as you see fit. And be aware of the fact that in some practices, there will be small sample sizes. So you'll only have a handful of patients, which could make, for some extreme variations in the data. And we have worked on looking at how we would define practice sizes to account for those kinds of things. And just to say, not all variation is bad. And if it was only bad, then it would be easy. You'd be able to quickly and easily say, oh, well, we can see this, so we must do that. I think the challenge that we see in this space is how do you reduce the bad variation while preserving the good variation? Because every patient is an individual and every patient is treated differently and they have a different set of circumstances. So it's about managing that. You don't want to be so absolutely strictly bound by that one measure that any variation offered is considered to be out of the benchmark. That's not how it works. So what we're really looking for is your input, and to ask what questions would you like to see answers to from the kind of data that we're currently working with, but ultimately going forward. So in an outcomes-based setting, what information do you feel would be really useful to you in your general or in your clinical practice? And so what measures are you interested in? And this is my plea to you, are you interested in participating in developing these metrics? At the Clinical Advisory Board, we have a practitioners subcommittee, so more of a technical working group at the moment. And so we would, if you're interested, we would invite you to participate and step forward and say, this is what I think I would like to know more about, or we as a group would like to know more about. And I think probably the most important part of it is that this is something that you as the doctors would own. And we would, the Clinical Advisory Board would work with you to facilitate this. So having many years of experience developing indicators, we can offer, sort of ways to get over some of the hurdles and some of the technical issues, and just be part of that journey, walking with the doctors in a way that'll get us all to the same point that we want to at the end, which is ultimately to be able to improve quality of patient care. So I feel like I whizzed through that rather quickly, but I know that I'm sure everybody is pretty much ready to head off. So I have left my email address there if you want to email me directly or to go through Sama. You can also contact Louis. There's a number of different ways of getting hold of us. So thank you very much for your time, and I'm happy to answer any questions. Thanks.
Thank you very much, Jackie, for that insightful presentation. I think let me just go through some of the questions. I think you were very really considerate. You really just summarized, but we could tell what you were talking about. The first question that is up there to you is, how do you assess care of a patient who attend different providers, e.g. flu vaccines administered by nurses, doctors, employers, pharmacists, and even medical aid schemes? That's the first one. The second one, it says, can the data from HQA make robust recommendations with regards to the structure and implementation of the NHI. Over to you, Jackie.
Thank you. And I think those are both good and interesting questions. So perhaps just to tackle the first one, there is an algorithm that we have developed which really links patients or currently members of a medical scheme to a practitioner. So we realize that people do move around and they do access care from various different places. So if a patient's moving between doctors, then there's an algorithm that links them to the doctor that they most commonly use or they most commonly visit. So if they happen to be on holiday and they go and visit a doctor there, that's, that doesn't muddy the waters. The way that if a patient's gone and had a flu vaccine from a pharmacy and they've claimed it from the pharmacy, or they've had it through a wellness day and it's been claimed through there, sometimes those don't always come through. That'll be linked to the doctor. So we work on the assumption that at some point during that care journey that the patient has with the doctor, they've said, you know what, you need to have a flu vaccine. It's not necessarily about the doctor giving the flu vaccine. As long as the patient goes out and has one, then we'll attribute that to that doctor. So that's how we link it, and that's some of the technical work that happens in the background. With regards to NHI, I certainly think that we have a wealth of information that can be offered and can be shared, and it's part of the relationship that we're building with the Office of Health Standards Compliance, because that's certainly where they are heading and looking at where we can align and where we can support them in that journey. So I think that at the moment, the data is analyzed in a particular way, but there's many opportunities for looking at it in ways that could support recommendations to the NHI. Thanks.
Thank you so much. You also mentioned, Jackie, something about individual practitioners wanting to participate. How do you do that?
Well, if someone's interested or if there's a practitioner group that's interested, they're welcome to email me and we can start a conversation. I think that it would be challenging to work with a massive group of people, but I suspect that actually it's going to be a more, manageable, smaller group of people who ultimately, really are interested in getting involved. And we will want to engage all along the way as we go along, giving feedback and updates and so on. So, yeah, but you're welcome to email me and I'll happily start a conversation around this.
Thank you so much, Jackie. Thank you for your insightful presentation. Let me just check if there's any more questions. Oh, I think there's the last one there. It says, has anyone taken the time to measure the time wasted by practitioners arguing with medical aids regarding approvals for medication and or procedures? We spend hours on the phone, which could be spent better treating patients.
Yeah, unfortunately, we don't have an indicator for that yet. But it would be a useful one to have. I mean, I certainly think, though, to that point, we're very mindful of the fact that there's a huge amount of time taken on administration. And so that's sort of something that we really are very careful about, that in this process, we're not creating a greater administrative burden. That this is something that's simple and easy to use. So we certainly don't want to add to time spent or to contribute to the burden of sitting on the phone and arguing. So yeah, but we haven't measured that yet, no.
Wow, thank you so much, Jackie. I truly appreciate that. Let me just check if there's any. The last one let me just check. It looks like there's one. Dr. Kasim says, shouldn't doctors be paid a facility fee?
Well, I think that's something that's going to come up for discussion under the NHI, certainly. So we don't have any control over what the doctors get paid. But yeah, I think the point is taken.
No, thank you so much, Jackie. I think we truly appreciate your time and your insightful presentation. On that note, I would like to take this opportunity to thank all of you. I think we've had a very insightful presentation. As you know, as always, these virtual events cannot be held without the tremendous input from those behind the scenes. And I would like to thank all the summer personnel who really worked very hard, to make this event as a success one. And then I would like to thank our chair of the association, my colleague, Dr. Angelique, for the introductory remarks and for introducing our speakers. And naturally, I would like to thank our guest speakers tonight, Mr. Porter, Dr. Van Sayer, Dr. Muat, Jackie. You have all provided some exceptional information to us tonight. Information I'm sure many of us will be digesting over the next few days. Of course, measuring and reporting clinical quality is a vital part of providing quality health care. I'm sure that is obvious in our country. And I thank you all for taking the time to share your thoughts and lessons with us. It is through collaborations such as these that we are better prepared as clinicians to understand more processes that affect our own practices. And I thank you again for being here tonight. Thank you also to everyone who joined us tonight. Your involvement in these webinars is essential, and I'm extremely overjoyed to see the high level of interest in this and other webinars we've conducted. We'll certainly continue presenting these sessions as we believe they play a critical role in helping the nation and also to educate, inform our members on an ongoing basis. With this short remarks, I formally close these proceedings. Thank you. Natural say good night.